Day. Welcome everyone. The Committee on Health, Tourism, Historic Preservation, Land and Justice is now called to order. Today's Tuesday, October 20. The time is 4:37 p.m. Notices for this roundtable hearing were disseminated via email to all senators and all main media broadcasting outlets on Tuesday, October 13th, and again on Sunday, October 18th, 2020. The notice was also published in the Guam Daily Post on the same days. The Zoom meeting is hosted by the Guam Legislature's MIS staff and my committee staff, and the host will mute all Zoom participants until called upon by the chair. Those testifying shall be recognized by the chair, and please state your name for the record-keeping purposes when called to speak. We will receive today a presentation by Public Health, and then others who are here to testify, including Dr. Wen. And then we will open it up for the panel of senators to ask questions of all of you. I'd like to recognize my colleagues who are here, beginning with my Vice Chair, Senator Sabina Perez, Senator Will Castro, our Minority Leader, Senator Terlaje, our Assistant Majority Leader, Senator Kelly Marsh Taitano. Thank you for being here. All right, I'd also like to thank the Department of Public Health and Social Services Director, San Agustin and his team, of course, and we'll get right to it. Okay, so this is a roundtable. It's not an oversight hearing, so no one will be sworn in. We are looking for, ideas and ways that we can assist in improving the current processes. All right, so this roundtable will focus on pre-hospital isolation and care for COVID-19 positive individuals. Discussion on this topic was compelled by questions and concerns of this committee and stakeholders on the correlation between the level of monitoring, supportive medical care to the hospitalization of COVID-19 positive patients in isolation and to mortality or survival rates, and clarifications needed on any additional care or planning for COVID-19 positive patients in isolation to increase their chances of survival, to avoid complications, and to avoid hospitalization. So we've asked the Department of Public Health and Social Services to provide information on the guidelines and procedures for monitoring and pre-hospital medical care for those patients in home isolation and isolation in government facilities, and an assessment of how these protocols help to prevent patients from needing hospitalization or waiting too long before they seek hospitalization, and recommendations to improve these protocols or resources that they might need from us at the legislature in order to improve these protocols. We also invited Dr. Mike Cruz, who is the State Surgeon Cell leader. He is also the Chief Medical Advisor to the Governor during this health emergency. We invited Dr. Juan Wen, Chairperson for the Governor's Physician Advisory Group, and we've asked them to expound on the role of the government and the private clinics and to provide feedbacks and recommendations as to best practices for the monitoring, isolation, and care for these COVID-19 positive patients prior to hospitalization. The committee's also invited the participation of community medical professionals to provide recommendations on best practices or just simply how we can tailor this to Guam and meet Guam's particular needs. So we're looking to be proactive here. I mean, public health is working very hard already. We know this. They've got their procedures in place, but we're just trying to see if we can be proactive as possible given the rates of infection that we are currently facing. For example, right, do we have enough equipment to ensure that patients are able to monitor their oxygen levels, or are we able to get food to these patients without them having to go get food for themselves and risking, furthering the spread of this infection? So we're going to begin with a presentation on the current guidelines and protocols by Public Health, and I'm asking Public Health. So we've heard, about your protocols in the media, of course. So if you could get to the cutting edge of those and what do you feel might be your challenges, or how we might be able to assist in those protocols, or which ones you feel are very effective for for taking good care of these patients. So Director San Augustine, I can't really see you, but you're there?
Well, Hafaday, and good afternoon. This is Deputy Director Terlaje. Director is in between meetings, so he should be arriving in here very soon.
No
of course,
problem.
I'm fortunate to have with us our Deputy Director, Lori Duenas. And we will take a moment and we will introduce our staff from Public Health, starting with our new IC. Tom?
Well, thank you. Good afternoon, everyone. Good afternoon, Chairperson Terlaje and members of the committee. My name is Tom Nadeau. I am currently the Incident Commander for the Public Health Response. Thank you.
Senior?
Good afternoon. My name is Zena Piscina, and I'm the head of the Nursing Resource Command for the Department of Public Health and Social Services.
Thank you. Annette?
Hafaday, good afternoon. Annette again, I'm overseeing the Epi Surveillance Branch for the COVID response.
Chima?
My name is Chima Mbakwem. I am the MedOps Chief for the response.
So thank you, Madam Chair, for giving us this opportunity to address some of your questions. And hopefully we will collectively come together for new ideas and new ways in which we can move forward. So at this time, I'd like to go ahead and turn the floor over to Chima.
I think Ms. Tom. Tom has to present.
Oh, okay. All right. On slight correction, we're going to have Mr. Nadeau, I understand, do an overview.
Thank you, Deputy. If I have access to share the screen, that'd be great. May I have the ability to share the screen, please? Thank you. So can everyone see the screen? This is a flow chart of the quarantine process. Is everyone visible? Is this everyone visible to everyone? Okay, if so, I'd like to start. Hafaday Chairperson Terlaje and members of the committee, we would like to begin this presentation by providing you all a quick overview of the process and how a COVID positive individual is placed in isolation, whether at home or at the government facility, and his or her eventual discharge. This process will be presented utilizing the flow chart as shown on the screen. And please note that these steps include certain quarantine steps, which you may wish to ignore since this is a focus on isolation. So step one, upon receiving notification of an individual who tests positive for COVID-19, it triggers a series of actions that are led by the containment branch of our medical operations section. This begins with step two, where contact with a positive case is attempted by a telephone call. If such call is unsuccessful, as noted in steps three, the team will conduct a home visit utilizing the address that was provided to them. However, if a home visit is also unsuccessful or not possible because the incorrect address or no address was provided, the team looks into other resources such as the Guam Police Department and other programs of the Department of Public Health and Social Services to get an alternate address or phone number. As noted in step four, when contact is made with positive individual, the team conducts an assessment of individual symptoms, determine any underlying medical conditions, and make inquiries about his or her current living arrangements, which includes household contacts. In addition, team gathers updated information about the individual, especially his or her contact number. On a side note, for any household contacts identified during the initial assessment, the team initiates quarantine procedures for each. For any other contacts outside the household, they're referred to our investigation unit. During this assessment, the team evaluates the home of the positive individual to determine if home isolation is possible. If the home is suitable for isolation, the team makes arrangements for home visits, which is noted in step 5. However, if it is determined that the home isolation is not possible, the team prepares the individual for transport to the government-run isolation facility, provided the individual does not have any serious health conditions that requires an emergency 911 call. I believe it's important to note here that not everyone who are recommended, encouraged to go to the government isolation facility, the DPHS recommends. Few have refused to do so. For an individual agreeing to go to the government facility, we seek a written waiver, provide information about the isolation, and conduct intake assessment as noted in step 6. Let me move the chart so I can better see the graph. There we go. Okay. Continuing on. So whether the individual is at home isolation or government isolation facility, this person is monitored via phone call as shown in step 7. These phone calls are made at least once every day and possibly even more if time and resources permit. If during the call, the individual reports COVID symptoms, then the number of monitoring calls increases to 2 or more times a day. I'd like to note here that these phone calls are to monitor the individual to identify symptoms for COVID. It is not, and I emphasize the word, it is not intended for medical monitoring to provide medical treatment and care. Furthermore, it is the responsibility of the isolated individual to notify public health of any changes to their health during these calls, and when necessary, the individual is to call 911 for emergency assistance if at home isolation, or notify public health or 911 if at government isolation facility. On occasions, the team will conduct home visits to those who are in home isolation to ensure compliance, while also providing wraparound services as needed. As further noted in step 7, an individual may move to another isolation location if and when necessary. And finally, when completing the isolation period and meeting the criteria for release, arrangements are made for the individual's discharge, which will include the issuance of clearance form to discharge individual. So that was a real quick, broad overview of our isolation process, Madam Chair. So if there's any question, we are available to take that question, but we're also ready to proceed on to the further question that was provided to us. DD2. Thank you.
Mr. Nadeau, can you just clarify when you say they're monitored for COVID symptoms, what exactly are you monitoring?
I'll allow Mr. Chima, since he's actually oversees that particular section, I'll give him the opportunity to respond. Chima, would you like to answer the chairperson's question, please?
Okay, so for monitoring, we usually monitor for shortness of breath, fever, diarrhea, and all other, if I can list it out, all other COVID symptoms. Because what happens most times is the patients are asymptomatic. Most of them are asymptomatic. So we try to monitor to see if they develop symptoms within that period of isolation. If they develop symptoms, then we can now provide guidance on what next to do.
Okay, all right, thank you. Please proceed. So to my colleagues, yes, I gave them again another list of questions to just at least address some of the issues that have been brought to my concern. Please proceed.
Madam Chair, would you like me to leave the flow chart on the screen, or would you like me to stop sharing?
It's up to you. You can.
DD2, shall we put up those questions so that they're seen on the screen?
That's
Yes,
fine.
we can go ahead and put up the questions then.
Okay. You have that on your end, DD2?
Oh. Okay. Chima, you ready?
Yeah, I'm ready
All right.
for the questions.
DD2 means Deputy Director Laurie Duenas. Is that right? Deputy Director Duenas.
You have the questions.
Yeah, but we're not the host, so I can't just put up a,
We can share it.
yeah. So if,
Oh,
I guess we can read them off if that's what you would help.
whatever's faster. My
All
staff
right.
can also make you a host if you have something prepared to share. We weren't aware.
We were just going to post up the questions. So if that can be done on your end, that would be wonderful.
Yes.
All right. In the meantime, we'll continue. Ready to?
Yeah.
You got your questions?
Yeah, but you're gonna ask me so I can answer. Read out like before, yeah.
Okay.
Number one,
What medical personnel comprise the home isolation monitoring team?
for the home isolation monitoring team, we have a registered nurse, we have LPNs, we have CNAs that are on the team, and also a doctor on call. We also have social workers on the team.
What are the COVID-19 guidelines for the medical management and level of monitoring of positive patients in isolation? Are guidelines based on the different levels of severity of illness and symptoms? What is the goal of care provided to patients in isolation?
Well, we do not, DPHSS does not provide medical management. What we do is symptom monitoring.
Good.
Yeah, that's the answer to the question, yeah.
Okay,
So,
please proceed. Yeah.
Okay. What are the types of medical treatment provided to COVID-19 patients in isolation? Frequency of monitoring.
for people in isolation, we at best try to do twice a day symptom monitoring, like we presented in our flowchart.
Yes.
If the individual has symptoms, we try to make a second call during the day. If they don't present any symptoms, we leave it at one call a day. But this is based on our resources and the number of people being managed at every point.
What does that mean? Please clarify. Does that mean you do less than one a day sometimes?
Yes, because right now at the beginning, the numbers were very low. We had less than 100 or 200, but presently we have more than 1,000 people in isolation. So that's why we talked about resources. If we have available resources, we can now reach more people twice a day.
Okay, please proceed.
What are the determining factors for the initiation of hospitalization? At what point are patients advised to seek medical attention? Who is making this determination and who is advising the patients?
So during the initial intake of isolation, individuals are also, we also advise the individuals to monitor their symptoms and also contact their provider if they feel sick or call 911, because we don't provide any medical, we don't have any medical management in our monitoring system. What we basically do is symptom monitoring. So based on that, it is the individual that makes the determination of when they are sick, or the monitoree, who is a public health official who is doing the monitoring, can also advise based on the severity of the symptom that is self-reported by the individual.
According to a review of the average illness course of COVID-19 on Guam, presented by Dr. Felix Cabrera during a governor's press conference on October 15th, the start of the COVID-19 symptoms usually occurs by the 5th day of infection. And on average, COVID-19 positive patients are hospitalized by the 8th day of the course of the illness, which coincides with CDC's data on the medium time difficulty of laboring and breathing. Given this data, is there a protocol in place for increased monitoring and aggressive supportive care prior to the predicted onset of severe symptoms?
Okay. We are, first of all, we are unable to establish the date of infection. Going out with the data that he presented, this is this clearly shows that we need to know the day the person was actually infected. But what we use is surveillance data. So the individual, the time of infection is not monitored using surveillance data, and then we monitor the individuals the same way we monitor them, and the intention is to limit the spread of the disease and also respond according to the individual's report of their system or their symptoms. Sorry.
All right, Mr. Deputy Director, do me a favor and just take down this screen. I'd rather we see you, and yeah, I think it's just distracting. Yeah, and just go ahead and proceed as quickly as you can.
All right. Are there identified predictors of clinical deterioration that aid in early identification and management of patients at risk, who therefore should receive additional monitoring and aggressive supportive care?
We base it off the self-reported symptoms and severity of the individual. And that is what determines what kind of support we provide the individual. But like I stated earlier on, we do symptom monitoring and refer the individual to go to the hospital or visit their PCM if they have severity in any of their conditions.
Does the Department of Public Health and Social Services have the equipment necessary for effective monitoring? Is this equipment given to patients, including oxygen monitors? Is there any vitamin or other nutrition given or recommended to patients?
Okay, again, home patients are monitored for COVID-related signs and symptoms. Our nurses educate patients at home and walk them through proper temperature check if they have thermometers. And then this is recorded by the patient and the isolation unit for trending and also reporting to the medical director or the nurse practitioner in preparing for their discharge. Secondly, the nurses also provide initial assessment and intake, which is followed by the home assessment and continued monitoring. It is during this initial phase that we identify the need that they would have, and we support them if we support those needs. These resources could also be anything from food to medication or even educational materials.
Is a medical assessment done on each patient? Is the primary care doctor notified or consulted on patients?
Okay. At the initial intake, we try to identify during the initial intake, part of the questioning is to identify the patient's comorbidities and other issues that are ongoing with the patient or the individual. Then we notify our own medical director or nurse practitioner of all admissions within 24 hours, and then also make sure that we report to the nurse on duty if the intake is at home and not in the facility.
Is there a correlation between increased monitoring, aggressive supportive care, and early hospitalization of at-risk COVID-19 positive patients and mortality or survival rate? What are the considerations?
This will require more research and data. Right now, we're not collecting that data.
What percentage of positive cases were accepted in government isolation facility? What percentage was entire households isolated?
So presently, up to yesterday, we've had 3,275 positive cases. 74% of that number, which is 2,693, have been isolated at home, and 16% of that number, which is 582, have been isolated in the government facility at one time. So.
Okay. Does isolation allow for travel to a grocery store or other places to get food?
No.
Exercise, church?
No.
So may I ask right now, how do they get food?
So normally what we do is for the families during the initial intake, part of the assessment is to find out if they have any community support. So if they don't have any community support, that is when we provide them the option of going into the government facility. But if they have community support, then we will guide them on how to receive food from family members.
Okay.
For those on isolation, how many ended up in ER or hospitalized?
So with regards to hospitalization, that data would definitely come from the hospital because it's very difficult to provide on our own end. An example is when we make the initial calls to a patient to an individual in the morning, sometimes they deteriorate after the initial call and they end up going to the ER. When they visit the ER and they come back, if they don't notify us, there's no way we will know that they visited the ER. So most times the information lays with the clinic, unless they spend additional days in the clinic, in the hospital, and we make the second call and we can't reach them, then that's when we try to figure out where they are.
What are the final numbers of positive cases found with the rapid engagement process that took place over the weekend? How many of the
I think you reported on this to the media already, right?
Yes.
Okay.
So we'll skip number 13.
What about the isolation part was not reported to the media. How many of them, what percentage agreed to or was put in government isolation versus home isolation?
Only two of them as at Monday agreed to go to the government facility.
Okay, and Chima, earlier you said 74% were isolated at home, 16% were isolated in government facility, but I
Yes,
think that's
ma'am.
90%.
No, that is 16%. So what the numbers are the ones that have completed isolation. Most of for hold on, hold on, ma'am. I think I missed the numbers.
Okay.
Yeah,
Right.
let me correct the numbers.
So it looks like the majority are like 75%, if that's correct, like 3/4 of them are isolating at home and only 60% are isolating in a government facility.
Yes, we have more people at home than the government facility.
All right.
So the last part of that question was, what was the reason given for refusal to go to a government facility? What instructions were given to the patients and to the families of positive cases who chose to isolate at home? Are family members of isolated patients allowed to go to the store or exercise?
So what was the reason given for refusal to go to government facility? Some of them don't want to be separated from their families. Others are in good home setting, so their home is okay for isolation. They can identify a room with a bathroom to isolate successfully in the house. And then in other cases, the whole household is positive, so we don't have to move them to the government isolation. And then for the other question about what instructions were given to patients and to families of positive cases who chose to isolate at home, we always tell them to remain at home, and then we do we do daily monitoring for them, and then do random compliance check for these families. And then the last question, household members, for any isolated individual, the household members are in quarantine, so they are not allowed to go to stores or exercise.
The second part of this paper is government isolation. Shall we begin with that or
Sure, yeah, as quickly as you can. I was hoping you were going to incorporate this in your overall presentation, but just please proceed. We're almost done. Yeah, 8 more questions. Yeah.
Government isolation? What medical personnel comprise the government isolation monitoring team?
Good afternoon, everyone. So I'm going to take this piece of the questions since I manage the nurses over at the ISOFAC. So we have approximately 10% that are registered nurses, 5% that are LPNs, 85% CNAs, that's our certified nursing assistants, and a public health MD or NP who rounds on patients daily or as needed. And how often are they monitored? These patients are monitored 2 to 3 times daily for COVID-related symptoms, and that entails temperature checks, oxygen saturations, and also a wellness check. In addition, our nursing staff is also responsible for meal deliveries like 3 times a day, plus personal belongings that they drop off when families drop anything for the patients. So nursing staff knocks on each of the patient's doors to ensure that they are aware that their meals are there, because they leave it on a chair outside of their door. So in actuality, if you think about it, patients are actually being monitored 6 to 7 times a day. Also, upon admission, we do an initial screening That's conducted to identify like comorbidities that makes it be exacerbated by the COVID-related symptoms, allergies, and anyone at high risk. And nursing is really notorious for marking these abnormalities. So if they see anything out of the norm, they're going to highlight what we use to report off from shift to shift. So so everyone is aware, and then they closely monitor these individuals.
Are there identified predictor or clinical deteriorators that aid in the early identification and management of patients at risk, who therefore
Yes.
should receive additional monitoring and aggressive supportive care?
Okay, I touched on that a little bit, but we do what's called symptom-based predictors, and that's what we use to detect early problems. So our guidelines are very clear, and our nurses review these guidelines with patients upon admission. So when our patients come to the ISOFAC, we go through every single instructions with them, what to do, how to monitor, or what to monitor, when to call us. They can call us anytime they want, but we also highlight what's really important for them to call. Examples include like shortness of breath, if they have chest pain or tightness, if they get lightheaded or have any serious discomfort. And patients are instructed to call the nursing station immediately. So when a patient is identified at high risk, like they have the COVID symptoms, or they're dialysis patients, or they have respiratory illnesses and so forth, they're flagged by the nursing staff, and this is endorsed from shift to shift. So when we know this, the patients are closely monitored, or frequently monitored them, the average 2 to 3 times a day.
This next question was touched upon, but I will go ahead and read it anyway. Is a medical assessment done on each patient? Is the primary care doctor
That's
notified?
been answered. That's been answered,
All right.
right?
Yeah, we did that. Yes.
All right.
So we do the same. Either it's home or facility isolation, we do the same kind of assessment, yes.
Oh, okay. Then just a minute, because it sounded to me like you were doing a more thorough assessment of comorbidities and any potential complications at the ISOFAC.
Correct.
I didn't hear that on the home isolation assessment.
So we have registered nurses that are in the containment unit. They take care of quarantine and isolation. So when we have quarantine patients, they call on. When we have isolated patients or patients that are positive, they do the same initial assessment as well.
Okay.
What are the challenges presented to isolation in government facilities, and how are these being addressed?
So of course, we hear about staffing. Everyone is short of staff. So we're being really creative when we staff the ISOFAC. We know that we don't really need as many registered nurses. If we have one on board, that's great. We utilize a lot of CNAs, but the work becomes really challenging when we have administrative duties like answering the phones or data collection or receiving family drop-offs and going to the rooms. And you're talking about 100 some patients that we have to give food to. So we go 3 times a day and drop food off to these patients. So this has been recently identified. And so we're requesting for more administrative help, like front desk assistance and so forth. So this has been submitted already. Also contracts, we were having some issues with our housekeeping services. Lately, we had issues with linens. When they say we don't have beds available, we do have beds available, but we don't have linens to make the beds. So we had a meeting today, and we've addressed this with Homeland and the hotel that we house our isolation patients and others. So this is being addressed. I think that's about it.
Next, how many cases from government isolation resulted in hospitalization?
So believe it or not, I mean, we have patients that do go to the hospital, but we average about 3 to 5 patients a month that actually get admitted. So that's not bad considering you get 100 some patients a day. Because we have a manual system, the information, we don't have the numbers offhand, but we can get that information for you. We just have to have someone extract that data for us.
The point I'm
Thank you.
trying to get there is trying to determine whether there's it's more likely you're going to end up hospitalized if you isolate it at home or if you isolate it in a government facility, if there's any data that shows anything like that.
Yes, we have lots of data. We just have to extract them.
Okay, all right.
Yeah. But Madam Senator, if I can answer for her, the reason for the government isolation facility is not medical. It is set up for people who do not have conducive home environment. So as a means of cutting off transmission in the family, we send them to the government isolation facility. That is the criteria for moving people to the government facility, not for medical monitoring.
Correct.
How many cases from ER but denied admission sent home were received at a government isolation facility?
This question was a little tricky, and I think it was asking how many patients from ER were denied admission. So just to let you know, our patients from GMHA and GRMC are priority. So if there is a patient that needs the assistance of our facility, they are the first to be admitted. No one is denied admissions. We do have the number of admissions from the emergency room, but again, we need to compile that data and then we can submit it at a later date.
All right. Yeah, I was concerned about, if they're serious enough to go to the ER, then maybe they needed additional monitoring by a nurse, for example, at the ISO facility, if they were encouraged to go there as opposed to going back home. Okay.
And the last question on this list is how many cases were sent home from ER to return for hospitalization?
That information would have to be obtained from the respective hospital. Yeah, we don't have that.
All right. Okay. Appreciate that information. Is there anything that anyone from public health would like to add as to the gist of these questions? All right. Then if not,
Add something at this time?
Sure.
Any staff?
Okay. So, ma'am, I just want to reemphasize that like I explained, we do not engage in medical management. Public health does not engage in medical management. What we do is symptom monitoring, and the reason is that the purpose of that is to identify the COVID symptoms and also ensure compliance of isolation. We're trying to make sure that those individuals are properly isolated wherever the isolation location is, and also make sure that the quarantine individuals do not mix with the isolated individuals, maybe at home or in the government facility. And the government facility was set up just for people who do not have conducive home environment. I just wanted to state that.
All right. And then did you say earlier that with your rapid engagement team over the last 3 days, only 2% were put into a government facility? So you're saying
Yes.
that the rest of them have suitable home facilities for isolation?
So we have families that have up to 20 people that are positive in that particular home. So that makes it suitable for them as an isolation location. And then we have individuals who have 2 or 3 rooms that people can successfully isolate differently from the other members of the family. That is how the determination is made. And when we make the determination and found not conducive, we offer the option of taking them to the government facility.
Okay. All right. I guess I'm still concerned that we have a 75% rate of home isolation versus government isolation. And it's clear that in the government isolation facility, we have nurses, we have 2 to 3 times a day they are checked. And that's, I guess, and we're not really very clearly, I don't even know if the people in home isolation always have thermometers or whatever, the other things that you're checking. You're checking temperatures, you're checking, you haven't mentioned the oxygen. Do you check oxygen levels or what do you do with that?
Yes, we do.
in the government facility?
In the government facility, correct.
And what if they're at home?
For people at home, they are advised, if so, because of the twice a day symptom monitoring based on resources, individuals are advised based on their severity to visit the hospital.
Okay. All right. Okay. And of course, I'm concerned about the comorbidities if they're really, being, like you said, tagged or highlighted, Xenia, when they enter a government facility. Okay. Dr. Wen, I'm going to move on to you. I don't know if you can tell. I wrote those questions. I'm just a lay person, so please forgive me, for the duplications and the, maybe inaccuracies. But the gist of what, from my view, it's that we've heard from the hospital, we're getting increased hospitalizations of people who are very severely sick, and the administrators suggested they're waiting too long. And so, and they were, of course, we're talking about COVID positive patients. And so even, they have a lot of them have comorbidities. I'm wondering, are they being monitored by their family physicians or not? I don't think it's part of the protocol at this time that the family physicians are being notified. So yeah, the gist is there a way we can improve their, their rate of survival, I guess, and and to decrease the hospitalization rate by just changing something in either home isolation or government ISO monitoring.
Okay. Thank you for inviting me to participate in this one. But now, first of all, I just want to let you know that I'm not here in the capacity of chairperson of the PAC. Like, we didn't have a meeting to clarify all the members. So I'm just speaking on behalf of a group of physicians that we get together to try to figure out what we can do to improve the care for the patient that are positive identified at the outpatient clinic. As a private physician, when we send the patient home, or identify them positive, they know, we tell them right away. And we often tell them just go home and watch for your symptom, and shorten your breath, you go to the hospital. And that's the worst thing that the physician can say to any patient, because they're going to look at you and say, doc, what can I do? What can I take? What I'm going to watch for? And, and that's very hard for us to say, you just take the temperature and take the cough and cold medication and you go to ER, you have shortness of breath. And we can do much better than that. We are 7-8 months in now. So number one is the people that go to Q factor for isolation. Those are mostly the healthy people with very little comorbidity, because those are people that want to get away from their family member that have high comorbidity at home. So that's not the high risk patient. Most of them in the isolation facility. Like I say, the ISO factor nursing staff are doing a great job. So you don't have anything adverse effect from the Q factor. The one to worry about is the one at home. The one that have high comorbidity, and we forget very often that shortness of breath is the last thing that we want to hear, because by that time it's too late already. There's such thing on this COVID-19 is that the silent hypoxemia. You can drop down in the 94, 93%, 90%, and you have no symptom yet. But when they get below 90%, they have shortness of breath already, and they have no ability to monitor their symptom at home at all. We do our best by calling them once or twice a day, but we're dealing with some patients that don't have thermometer at home, don't have a pulse ox at home. They might not have a car or a driver to get them to the hospital or to the clinic. And some of them truly don't know who to call. They might be giving information to call certain hotline to get information, but they don't call to the last minute. So what we did is we have a group of physicians get together saying, what can we do for all this patient that we send home? And that's the number one thing, is to intervene with them to decrease the rate that they show up on the ER, no death on arrival already. And, we got lots of fun, and we talk about this in the pack, and the several things is that, hey, we can buy pulse socks. Those are $20 a piece, are cheaper, we can use the government fund to do that. We can pass it on to the clinic, and every positive patient that have comorbidity, not everyone, I don't care they're 20 years old or 25 years old, they have COVID-19, they will be fine. But the one that we know who have comorbidity, we were interviewed in the clinic, that they have diabetes, hypertension, stroke, whatever, we need to give them a pulse ox to go home with, so they can measure the pulse ox at home. That's early intervention to the max that we can give to people at home. And those can be returned and desanitized and reused for the next patient. It's a very cheap thing we can do. The other thing is that we need to have a COVID-19 clinic for the high comorbidity patient. We don't need to see a 20 years old or 30 years old people that have absolutely no comorbidity like diabetes, hypertension, or anything. We need to have a clinic specifically for people with high comorbidity, that when I let the patient to go home, I say, you have an appointment with this clinic the next day. If they don't have transport, then we provide them transport. But they need to get to a clinic to do a daily monitoring and some teaching for this patient to be able to be face-to-face, one-on-one with a physician or NP or somebody that can tell them, educate them what to look for. And I think that they need to be a daily visit for this high comorbidity patient. And I tell you, you will cut down the rate of hospitalization, okay, and and cut down the risk of patient dying because we interfere with them way ahead of time. That's intervention that we can do. A COVID clinic will have a chest, the ability to do a chest X-ray, because we need to take an X-ray. Sometimes people sound fine. There's no way you can listen to a COVID-19 patient lung. They all sound good. But when you take the X-ray, you say, oh my goodness, it's totally look really bad and beyond what you can hear with your ear. So they can do a chest X-ray, they can do some blood tests, they can check the pulse ox, they can do education. It's a daily visit for this high comorbidity. You're talking about, not that many people, that have high comorbidity. So we can do that, we can manage that. But that need to be standing up somewhere that we have to do is much cheaper solution than admit the patient to the hospital and intervene them so late. So those are stuff that we have to do as an outpatient and for our community. And so we have to do that. And, zero down area, the Gilbert area, those are very high risk patients. It's just because not so much about they have a lot of comorbidity, which they have, but those people, they don't have a right. They wait to the last minute. They practice, traditional medicine. That's what we hear from our patient to the last minute when they run over, so from us as a private physician, we say, put the clinic out there at the site. We can run that clinic 4 or 5 hours a day. They just walk over and get seen. There's no cost to them. And that's the way that we capture those population, because we can remember those people go to work in our community also. So there's a lot of things we can do to improve. So, like I said, the pulse ox daily visit to a COVID-19 clinic by itself, if you can put that together, we save lots of money and lots of life. So that's how the private physician we see, on our daily practice, because I see it's not good to tell the patient, just go home and watch your symptom. No, we got to offer them something. So the high risk, high comorbidity is the one at home, not the one in the isolation Q factor. Those are just try to get away to protect the family. That's all it is. So we had to concentrate on people at home. So.
Thank you very much, Dr. Nguyen. I'm very glad to hear that. It's opens my eyes a little too. I had it reversed in my mind that, yeah. I guess I had thought of creating teams for every village of, like a monitoring teams, because I thought that the monitoring was a lot medical and not as much enforcement. But I think a clinic is good. It's just, sometimes they have a problem getting there, or if they start to feel worse, they might have a challenge to get there. But okay, I'm sure there's a lot of ways to think about that. Thank you. I'm gonna share with my colleagues, allow them to ask some questions. I know we all have, and then we'll just make some quick rounds. Yeah, so Senator Perez, please begin.
Thank you, Madam Chair, and thank you for this line of questioning and all those that have given their time today to provide testimony, and for all your hard work. The reason why we're all here is we want to help with the preventing the spread and also helping our community. So thank you so much, Dr. Nguyen. I really appreciate your testimony, because I think this provides a solution to helping our community fight the virus should they be positive. And I fully support this, and I support the efforts of the chair to get more resources to our people so they can receive the help that they need. So I guess a question for Deputy Director or the Director of Department of Public Health. Is this something that can be requested, considering there's CARES money? I mean, I'm assuming there's CARES money still available. Is this something that the agency is willing to pursue to get funding for a COVID clinic for those that are experiencing comorbidities, get more, medical assistance, in addition to all the other that you guys are in need of? Has this been researched or attempted, or is this something that you're willing to move forward with?
Senator Harris, co-chair, I want to extend my apologies. This is the director. I was attending to another department issue, and so my deputies were with you for the entire presentation. And if you would be agreeable, I could have one of the two deputies respond who was here for the entire discussion. But in terms of CARES funding, perhaps, Senator, if you're speaking with the ones at the within the department, those are earmarked for very specific activities, which we are working to put forward. With regards to CARES Act funding, perhaps that you may be referring to, that is with the administration. I have not requested for funding for that account for this very specific event. The idea of a clinic out there for a period of time, for a period number of hours, is something that is really in evolution. It is something that we were working as a result of the rapid engagement team, which at this point, I believe you've all been briefed on already. So that process started about last weekend. 2 weekends ago, I'm sorry, and then this past week we implemented it, and now we're on our second week of that. But perhaps Deputy Director Ugden or Duenas could add a little more to the question you have before the department.
Absolutely, Director. The population that we're referring to, especially in our northern area, and I apologize for the noise. We have a construction going on in our building after 5 o'clock, and so they've already kicked in. But the Department of Public Health and Social Services has a long history of providing outreach into this population, and part of that outreach includes having a mobile clinic that has gone out into this area. We looked at it two vision. One was one that we would bring out and actually have there for a period of time, especially around like immunizations and so forth, because we want some of the younger children to have access to that service. And sometimes families are very slow to come into public health or any clinic for that matter to get their immunization shots. The problem we had with that at the time was a certain level of vandalism that took place at our facility. And then we were also looking at the ability to have something that was on wheels, something that could be brought out. And then when we exit, we actually exit with the structure as well. So we've looked at it in different ways and we've had different options. Matson company actually donated a container that was adjusted for doing exams and so forth. So, I know that's something that I think the department is willing to revisit. But to confirm to it just at this time, I think we'd have to have a little bit more discussion around that. But, I'm all about having patients having access to care. And we know that COVID is, you can be feeling normal and within a short period of time have a lot of complications set in. So with that in mind, we definitely will have more of this conversation.
Maybe a transport service, sustainability and maybe transport.
And I know that it was mentioned earlier too with Chima, and our director is also echoing that as well, that, sometimes it's a matter of people needing perhaps stipends or tickets to be able to use transit. We know some of the barriers to that is that public transit has a difficult time coming into that area. So we've even done taxi vouchers for that matter, just so families could have access to public health services. So I think all of these need to be reconsidered. But, even then, we've done the SNP program, the Special Needs Identification Program, where we pre-register children for ambulance services. It targets more of the younger kids, but these are kids that are at risk, and they're pre-registered with the Guam Fire Department as first responders. And then that way, if a child has a complication, already the child's name is in the system, and based on certain identifiers, a location to the person's house. So we've looked at tackling things in different ways, and clearly it's something that we need to once more revisit and see if we can sort of approach it with more of the urgency of COVID-19 in mind.
Thank you. Just another question regarding the QFAX. So I think it was mentioned by one of the panel members that it seems to basically people that are going into QFAX are more, they're trying to protect their family who have comorbidities, and they themselves don't have comorbidities. So, I mean, what would, perhaps maybe flipping that where we have those that are in, is there a way maybe we can help those that have these comorbidities? I mean, is there a step that we can do to assist those that might be at risk of exposure? I mean, is there something that can be done in that regard?
Okay, so ma'am, in answer to your question, like I stated earlier, the reason for the isolation facility is to cut off transmission in a household. And part of the questions we ask is, if you have elderly people with comorbidities in the house, the reason for that is if you have a 20-year-old adult in a home with a 65-year-old with comorbidities, but without COVID, it is better for us to move the 20-year-old out of the house to the isolation facility so that there won't be any transmission at home. So if we're going to reverse it, it is also a situation where we have an elderly individual at home that has COVID who has a suitable home to isolate. So the main determinant is suitability of the home as an isolation facility, not due to comorbidities. But going back to what Dr. Wen is suggesting, COVID has clearly exposed the health disparities in communities on the island and everywhere in the world. So the health disparities that he's describing, which has to do with the poverty rate in these areas, the infrastructural problems in these areas, and then coupled with the fact that we have an infection that is widely spread in this situation, which is also the challenge we're having with TB on the island. So I think it's looking at it in its entirety. And that's why the deputy director is suggesting that we need to look at it more intensely before we make that decision of taking the clinics into the communities, looking at how sustainable that will be and how we can work around it to also address all these other health disparities in these communities. Because while we have these elderly people with comorbidities, we also have the younger ones with comorbidities that are not already infected. And the chances of them infected in that community is high. So it's looking at how to balance it. It's just not the hospital, the clinic alone. It's also looking at the housing issues. It's also looking at the education. So I think what the deputy director suggested is a good point, so that we can all sit down and articulate further on how to provide the needed help in the communities with these health disparities.
Thank you. I appreciate the response. Thank you, Madam Chair.
Thank you, Senator Paris. Deputy Director Duenas.
Madam Chair and the other senators, one of the things that, I really support having, like, your mobile clinic, but the problem is this morning I saw data that Dr. Carrera presented. And if we're talking about health disparity, it's not just one area. I mean, he was talking about 6 areas on this island that have a disparity as far as poverty, as far as access to transportation, and all of these things. And the number of cases, while it is higher in Dededo and Chico, it is also high in Santa Rita, it's high in, Barragata, and Tamuning. So we would really need the time to analyze this and then make decisions, because if we started and it's a mobile that's just going to stay put, you can't keep moving it around. And if you can't move it around, then we're going to have other populations that are going to have a hard time getting over to one clinic. So we really need to, evaluate this. Thank you.
Thank you, Deputy Director. I know my colleagues are waiting to ask some questions, but I'd like to welcome Dr. Akimoto. And if Dr. Akimoto, if you'd like to present something, were you able to listen earlier on? You're welcome to present if you would like.
The volume,
He's on mute.
but he's got, I think he's got.
No, I just want to listen. Thank you very much for hosting this. Thank you.
All right, thank you very much. Okay, Senator Taitukwi.
Thank you, Madam Chair. Thank you, everyone, for being here. It was funny, Dr. Nguyen, I was just thinking about the outpatient clinics that you brought up. I mean, that was going to be my question of the evening, to talk about outpatients and how how well they're doing in the U.S. mainland, actually, for COVID. And they're basically outpatient for COVID. And reading some of the information that they're putting in place, it's actually kind of helping what they're doing. And I'm glad that you brought it up, because for you to say something like that and you be a part of the doctor's advisory group to the governor, have you proposed this recommendation to do this outpatient clinic, COVID outpatient clinic to them? And what was the response to something like this?
I think the outpatient clinic for COVID-19 have we kind of batted around our group of physicians for probably the past 1 month or so. I know we have one brief discussion with the governor in the past week or so. It have not been discussed thoroughly in the physician advisory group as a whole. We plan to talk about it this coming Thursday to get an input from the physician advisory group. Like I said, I talked to Dr. Jody Nagan, which is the main person for the GMH, and she support that. It's a wonderful idea that we try to kind of do a lot of prevention for this patient that have high comorbidity, to try to prevent them from getting to the hospital at the later stage of the disease. There are a lot of things we can do to try to treat them and educate them as outpatient. Like I said, so it's not formally discussed yet in the physician advisory group, but we will talk about this Thursday, and then we bring out advice to the governor probably sometime this week sometime. But we need to push this really quick because, like I say, we kind of behind the power curve already.
Right, the sooner the better. I mean, they've been
Yes.
doing this in the mainland already, and you said, you hit it on the nail when you were talking about screening these individuals pre-done. My other question was, when you meet, maybe it was answered earlier, I'm not sure, but when you meet with individuals who've tested positive, at that moment, knowing if they have any comorbidities at all, do you recommend they go straight to the hospital, or do you just wait until something comes up for them to go to the hospital, especially if they have diabetes, obesity, that there is another facility that they can be placed at and not at home? Because from what I gather, these things come up really quick. I mean, you're the medical, what's the medical term of it? It just comes.
Silent hypoxemia.
Yes. Okay. Thank you. Thank you so much. So, really quickly. So, what is the process? I don't know if I should ask Chima or public health this question, but when you do go out and test them, and you find out they do have these comorbidities, is there a particular place that you send them to and not let them stay at home?
When we identify a high comorbidity patient in the clinic, we check the pulse ox, and if they need to be, they will get a chest X-ray, because sometimes, like I say, they can look fine, but the chest X-ray look really bad. If the chest X-ray look bad, then we, like today, we transfer the patient to the hospital right away. Even when the patient is not that symptomatic, like I say, if the film of the chest look bad, you're gonna jump ahead of time. So this is where it's so important we have the ability to do a chest X-ray in the COVID-19 clinic, so we can interfere with the patient a lot faster. We have a patient last week that the chest X-ray looked somewhat not very good. She's still set at 98%, but 2 hours later, the family called. Now she go down to 94%, at home. So it's very important that pulse ox need to be at home. Like I said, we're going to push the PAC, going to try to push to see if we can use some fund to purchase those pulse ox to give to these patients that have high comorbidity. They are really cheap. They're less than $20, and they're reusable. As they recover from the COVID-19, they can turn in, we desanitize them, and we use it again for the next patient. So that's something that we can do. So yes, we can do some certain stuff to try to prevent them from hit the hospital.
Yeah, because a lot of times those individuals who have COVID can't go to their regular clinic. So that's why I think this outpatient COVID clinic is such a great idea, because a lot of them can't go. So my question again to Chuma, when an individual is been tested positive and they do have a comorbidity, does that individual do not have the option of staying home to like the skilled nursing unit or something?
So, Madam Senator, the answer to your question is going to be from different. I'm going to answer it with different scenarios. First of all, it depends on the testing site. Was the person tested in his clinic, if the person is tested in their private clinic, the doctor would have the information about that person's comorbidities and also have the fact that the individual has COVID. Two, if they are tested in a community outreach, then that is when public health gets the result and do the initial assessment and ask questions about the person's comorbidities. If the individual is tested in the hospital, that is where that information will be at. So that is the baseline for answering your question. So number two, for monitoring purposes, public health is monitoring for the symptoms of COVID and not doing a medical management of the individual. So if we are going to go by the medical management of the individual, it is clearly going out of the public health scope and then transferring the public health, the medical responsibility to public health, which we are not trained to provide. So that's going to be a challenge for us. So coming with what Dr. Wen is saying, because what public health does is basically population management. We don't do individual management of cases. So these are different definitions of what we do and how the clinics come into what we do. Ordinarily, the way it's designed normally, if it wasn't an epidemic, is that the hospitals report, the clinics and hospitals report data to public health, and public health uses that data to make sure that we provide recommendations for the population health. So with the epidemic, what we're looking at is how to actually maintain population health with the strategies that we can afford, with the recommendations that we can provide from the public health perspective. So if we need to open a clinic for COVID patients, the clinic has to be run by a hospital or a private clinic and not by public health. So that's going to be.
Thank you for that, Chuma. I really appreciate your response with regards to that. And I hope there is no disconnect between the hospital and public health and the governor's advisory group, the doctors, that there's just this mesh coalition connection between the two of you. So I've just thought to myself, when you're out there in the community testing or people coming to public health to be tested, you're basically the front line for them. And then if they test positive, you get a phone call from public health. And at that moment, the assessment is taking place. So I figured that's the time where you have a chance to speak to the individual with any kind of comorbidities and provide them information. And that's my question, if that is being assessed when an individual is being, who's been tested positive. So, yeah.
Senator Tyree, if I can just respond to that. So you're right, when they do receive that call from public health, when we do an outreach, every positive result is called to the patients by either a physician or a nurse practitioner. And at that point, that's when the initial assessment is done. So they look at their comorbidities, and then they talk about isolation. Is it a patient that has mild or moderate symptoms, or do they have severe symptoms, or do they have critical symptoms? Hopefully they don't have critical symptoms at that point. Because then that would mean a hospital admission. But that is done, and then it's carried over by the registered nurse who takes over that case.
I see. So thank you. Yeah. Thank you, Zena, for that. And thank you so much for all your hard work. I know you have so much on your plate. I greatly appreciate it. And it's good to see you. It's comforting to see you here. Because you technically are the front line with the nurses. So at that point, my question, Madam Chair, was just to find out, it gives you the opportunity, public health, the opportunity to, well, let's put it this way. What if, Zena, what if when you make that phone call, whether it's a physician or one of the nurses, and the individual was told they test positive. At that moment, they're not feeling anything, but they're very scared, especially if they have a comorbidity like, oh my gosh, I have diabetes. Can that individual request to go go to the hospital, or request they can do that? And even if they're not, breathing heavily or anything like that, or just the anxiety, what do you
So, nurses are trained to do triage over phone or wherever. And one of the things that we learned in nursing school is if a patient says they don't feel good, they don't feel right, then you go with your gut feeling. And if you feel like you need to send them to the hospital, then you send them to the hospital to get checked. We also give them an option to come to the facility. So, I know we do, especially with families that don't have the equipment to monitor themselves at home, we have that option to do it at the facility at ISOFAC. So there are a lot of options, and it just depends on the home assessment and the triaging of the RN.
Thank you, Zena. Thank you, Madam Chair. I mean, my concern too is that they're all coming late. You have these individuals who it's late in the game. They should have came earlier, and that's one of the biggest problems that we're seeing. So thank you for the opportunity and for the answers you gave me. Appreciate it.
Thank you. Thank you, Senator. Yes, that's the goal of this, is to get how to get them earlier or treat them earlier, make sure that they're accounted for earlier. Okay, Senator Paris, did you have another question?
Yeah, just maybe a quick comment / question. I'm just actually trying to imagine this clinic already, and as a way to kind of address, prevent deaths, preferably. But I think, I'm a big fan of traditional Chinese medicine and these alternate modalities. And I feel like, where Western medicine, there's a shortfall in Western medicine, Eastern medicine can help provide some of the ability for people to heal. And I believe everybody has that power to heal. And we just need to boost their immune system, boost their wellness factor, so to speak. So just a comment that I like to make. And I whether it's a private clinic or affiliated with a hospital, I think, something that the community, I think there's a lot of people in the community that have skills in these additional modalities that can assist, that may be willing to assist in healing people that are in need. So that's something to think about too as well. Thank you.
Dr. Nguyen, are there discussions about things that we can give everyone who tests positive to take, such as vitamins or medicine or anything? Yeah.
There's a handful of vitamins that people can take. We were thinking either put that on the website or educate the public if they want to use it, like vitamin C, vitamin D3, zinc, melatonin, Pepsid, or Zantac, little baby aspirin. So there's a whole list of vitamins and supplements there that you can boost your immune system, to try to fight this thing. It's just that probably Guam don't have enough supply in the store for people to buy, but those something that we can give to the patient to take when they go home, if they have COVID-19 positive, so they kind of boost their immune system. So those things we can get, and again, just like Senator Perez said, there's other form of healing art that we do. It's just that the monitoring process is the most important thing. Again, the silent hypoxemia is the most important thing that we have to look for. And the post-ox is probably the most life-saving thing that people can have.
All right, thank you. And okay, and if Xenia said that all positive patients are assessed by a nurse or a doctor on that initial call. Chima, is that part of your process also? For those at home isolation, is it a nurse practitioner or a doctor that's calling them?
Trained social workers, LPNs, and CNAs supporting us in the home isolation. But because the questions are actually based off a script, so we have a nurse on call at each point in time when anybody indicates any symptom for the nurse to follow up with that individual.
Okay, but what about on the initial? I thought my understanding from your initial testimony was that there is no initial assessment for comorbidities, but I feel like Xenia is saying.
So for the initial assessment, what we do is we try to make sure that the individual is isolated correctly. So that is the initial isolation call. Then it's followed subsequently by the monitoring call, where we now have a long list of information that we gather from the individual, which also includes their comorbidities and their home situations also. So we make 2 calls. Initially, it used to be 1 call, but it used to take so much time for like an hour or an hour 30 minutes. But because of the high number of cases we had to shorten the initial assessment to focus on isolation first, and then the monitoring calls will now bring in all the other questions that we put out there for the people.
Okay, and you said that you're mainly doing management of the community, not medical management, but what are the enforcement, what are the violations that you are finding in home isolation? All right, what is the incidence of that?
So it's like with most cases is basically with quarantine, not isolation. So.
All right, so isolation. Oh, so
Yes, most of the challenges of non-compliance comes from quarantine, not mainly isolation.
Okay, all right, okay. And quarantine could be a family in the same house with a person in isolation.
Yes, right? Or someone from the travel quarantine too. Yeah.
Okay, yes, and yeah, I'm asking again because of the high, I mean, I remember Dr. Cabrera's presentation regarding this high home transmission. I guess they're getting this from public health data. It's, I mean, household transmission. And so, yeah, I keep thinking about this high household transmission, yet we have 75% of cases in home isolation. So, all right. Dr. Wen, this idea about, you know, monitoring them better, treating them perhaps, you know, checking more signs. I can understand, yeah, that we would like to get a clinic, for example, to do this exclusively, or maybe existing clinics to just set aside hours, such as urgent care hours, to do this exclusively. We've heard of the dialysis, one of the dialysis places does this, you know, takes COVID patients exclusively in a certain time period, and or things like that we all share, because I feel like if, just as we have in our regular populations, you know, we have enough work to go around, and if we have a lot of patients who have already, you know, existing doctors, existing clinics, that might be helpful. But yeah, for public health to do all of them, I'm not sure if that's possible. I know public health might end up doing those who are normally patients of the northern or southern, you know, clinics, or are you thinking those people would be going to this one COVID clinic? I mean, I guess I'll leave that for you to discuss, but I think a combination of everything, a combination of a site where people could go, a place they could call and be medically monitored, a place where an assurance that comorbidities are being assessed or being at least notified, or that their doctors are notified. Somebody is checking on those with comorbidities. Perhaps we do need a mobile unit for the phase that you described, Doc, that they're not able to be transported. You know, they're just not feeling well, or otherwise we're going to be relying on 911, which is going to be difficult also. But and these are, you know, positive patients. Yeah, transportation. Yeah, that's one issue by itself. But
yeah, it's kind of interesting that we had to look at clinic somewhere, just because what we noticed, our patient, they really scared to go to the hospital. You know, that's the thing. Well, I have a patient today that I had to transmit to the hospital. We had to sit there for 20 minutes, convince them this is the best for you, but they're so scared of going to the hospital. So we had to put a site somewhere. It's a difficult task to put on the site, because you have to have, like I say, X-ray lab, everything, but it got to be away from the hospital somewhere. So it's a challenging thing. can be a mobile unit. I got to work out a portable X-ray somewhere, but it's a logistic that you have to do.
Homo X-ray. Okay, thank you. Okay, so
Madam Senator, in
Yes.
response to your question, I think, Dr. Wen, the confusion here is if you're looking at the data that was presented by Dr. Cabrera, if you look at the whites, the rate of infection amongst the whites on the island, it was as high as the rate of the Chuukese. But what the situation is, pointing out the health disparities that I pointed out earlier, these are cultural issues and untreated conditions. These people have this underlying illness. They don't go to the hospital. They are not properly managed. So it is not that they are getting sicker because of just COVID. They are getting sicker because they have these comorbidities that are unmanaged or not properly managed. Then they get COVID. So if we're looking at solving this problem within these communities, looking at the numbers that were presented by Dr. Cabrera, we're also going to look at who bears the cost of that treatment, who bears the cost of the education to this community. So I think it's looking at it from the fact that this is peculiar to a community that has a lot of disparities amongst them, which are cultural, which are a lack of access to medical care. So it is also looking at how we can sustain this effort if we're going to move forward in carrying it out. It sounds good that we can do it right now, but the sustainability of this has to also include, we talked about moving them from their homes to the hospitals. We're going to consider how we're going to move these individuals from their communities to the clinic, or we're going to take the clinic to their communities. So I think it's going to be a better balance if we sit down and look at each community based on their disparities and figure out interventions that are peculiar to those communities.
All right, I appreciate that. Yes, and that's it. That's exactly another goal. Is I don't want, for example, income to be a determinant factor of whether you're going to survive this. I don't want that to be the case on Guam. I think Guam, we can do better than that. And so I'm very glad for public health's intervention. I'm very glad for your using data as to where we can go, where we can, put all our wraparound resources. And I'm very glad, Dr. Wen, that the doctors are also looking at ways we can take care of these patients that now we know, right? We have a very large population with comorbidities that are very much suffering. And we can, hopefully, we're going to try to do better. And so I'm Dr. Wen, did you want to say something? I was going, yes.
Yeah, we just want to make sure we clarify that the COVID-19 clinic is not distinguished which population you're coming from.
Right.
This is basically for everyone that have COVID-19 with high comorbidity. So it doesn't mean that you white or you Chuukese or anyone. Is for everybody that have COVID-19 that have comorbidity. Now the mobile unit that at the site, that's a second concept to reach out to a certain population. So those are two different modules that you're looking for in order to kind of attack this COVID-19 at two different ways. So the COVID-19 clinic, the most important thing, just because it's open out to everyone, doesn't matter what insurance or what doesn't matter what you can pay for or not. The key here is save life and cut the cost of hospitalization.
Thank you. Yes, I agree. It's a multiple pronged approach. And I think that's what we're going to need for our community. It's very unique. And so again, I want to commend public health for that type of approach. Dr. Wen, the physicians as well. Okay, so I'm going to I'm going to read what I wrote down as my summary of this. And it's very brief, but sounds like all positive patients are eventually assessed by a nurse or a doctor who tries to get medical history so that comorbidities can be identified. And this might not be at the first call, but it will probably be at a subsequent call. If you are home isolation, you're being monitored once a day, sometimes twice a day, depending on resources at public health, right? if you're in the isolation facility, the government isolation facility, you can be monitored 2 to 3 times a day, and food will be provided for you there. Individuals are being asked to monitor their symptoms, and if there are symptoms, then public health will, of course, take note of those and make recommendations. I think it was Dr. Wen who said today that if they wait for shortness of breath as a symptom, that may be too late, so that these x-rays of your lungs may be something that we can add on to our process at a certain time to be determined by the doctors. Some other recommendations were to provide pulse oximetry. That's to take your pulse and to take your oxygen levels, right? And maybe thermometers, or we'll look at other items that some of these homes might not have, and that might help public health or might help the doctors or the hospital to just be able to treat these people better earlier. And we were looking at, some of the recommendations for a clinic or other facilities, mobile or stationary clinics, or a combination of several different things that would allow easier access for those who, especially who are high risk, so that they can be monitored. And Dr. Wen's recommending on a daily basis. And this, we've seen, it's 5 days, 7 days, 10 days, that it's that short period of time that's very, very critical. So daily might be called for. And again, I am very grateful. I want Guam to do better than everywhere else in taking care of these people, especially we know the high comorbidities that we've always been plagued with here on Guam. And so we should react accordingly. We should tailor our isolation or our treatment for those who've been identified positive, to give them the best chance that we can. And again, I want to thank Public Health for all your efforts in this regard, your unending work and your dedication, and for really, it looks like a successful outreach that you did the last few days, and the data that you've shared with us. Dr. Wen, especially you also, and if you could just, I'm going to ask again, more, but think about it, look at your data, all of you, and just, we've got high transmission at home, or, in homes. And if we can lower that by changing perhaps our isolation locations, or that's what my initial idea was, but maybe we should flip it, and the 75% should be in government isolations, and that way it won't be spreading. But I've heard Dr. Wen describe the opposite. So whichever way will work. And I just hope that you can continue to keep looking at it and keep making your best recommendations. We will take these recommendations, and Dr. Wen, if it's something that we can do, for example, that the government has to fund or help set up or change the laws to accommodate this type of procedure. I'm just very sensitive to putting additional burdens on public health. So I'm hoping we're going to find a solution that assists in that regard as well. Maybe a whole other structure. But again, to my colleagues, thank you very much. I'm going to end this hearing. I know we could go on forever and ever talking about these things, because they're very close to us, very close to all our families, and we want to help. So thank you for your help. Thank you. Thank you all. We'll end the hearing right now at 6:10 p.m. Situ Asmasi.